Hello, class. Welcome to Flourish Nursing Academy. I am Tutor Godwin. This presentation delivers a detailed, evidence-informed explanation of the physiology of lactation and the principles that underlie the maintenance of milk production. Anatomy and development, mammogenesis. Breast tissue comprises glandular and stromal elements organized into lobes, lobules, and alveoli. The alveoli are the functional units, grape-like clusters of secretory epithelial cells surrounded by contractile myoepithelial cells and an extensive capillary network. Milk is produced in the alveolar epithelial cells, stored in alveolar lumina and ducts, and expelled by contraction of myoepithelial cells into lactiferous ducts and toward the nipple. Mammogenesis. The development of the mammary gland is hormonally driven. Estrogen promotes ductal proliferation and branching. Progesterone drives lobulo-alveolar maturation. And prolactin, growth hormone, insulin, cortisol, and placental lactogens contribute to secretory differentiation during pregnancy. By term, the breasts are prepared structurally for lactation, yet secretory activity is inhibited in utero by high circulating progesterone and estrogen. Stages of lactation: lactogenesis, galactopoiesis, involution. Lactation is traditionally segmented into phases. Lactogenesis, I, secretory differentiation, occurs in mid-pregnancy as alveolar cells acquire the synthetic machinery to produce milk constituents. Milk components are present, but full secretion is suppressed by placental steroids. Lactogenesis 2, secretory activation, triggered by delivery of the placenta and the abrupt fall in progesterone and estrogen. Over the first 30 to 72 hours postpartum, dramatic increases in milk volume occur. The transition from colostrum to transitional milk. Clinically, this is experienced as milk coming in, lactogenesis through, galactopoiesis. The ongoing maintenance of established milk production, governed chiefly by removal of milk, a supply and demand mechanism, and sustained neuroendocrine stimulation, principally by suckling-induced prolactin surges. Involution. With sustained cessation of milk removal, alveolar cells undergo apoptosis and glandular tissue regresses toward the non-lactating state. Neuroendocrine control, prolactin and oxytocin. Two hormones are principal, prolactin and oxytocin. Prolactin, secreted by anterior pituitary lactotrophs, is the primary lactogenic hormone that stimulates alveolar epithelial cells to synthesize milk proteins, lactose, and some other components. Basal prolactin levels are elevated during pregnancy, but functional effects are inhibited by circulating progesterone and estrogen. Postpartum suckling produces pulsatile, prolactin release, effective for milk synthesis when frequent stimulation and milk removal occur. Oxytocin, released from the posterior pituitary, mediates milk ejection, the letdown reflex, by inducing contraction of myoepithelial cells surrounding alveoli. The reflex begins with tactile stimulation of the nipple and areola. Afferent signals to the hypothalamus elicit coordinated oxytocin release. Oxytocin release is rapid and may be inhibited by maternal stress, pain, or anxiety. Neural pathways integrate sensory, emotional, and contextual cues. Oxytocin release can be conditioned by auditory or visual stimuli associated with breastfeeding or infant cues. Cellular mechanisms of milk. Synthesis and secretion milk is a composite of water, carbohydrates, predominantly lactose, lipids, proteins, casein and whey fractions, minerals, and immune factors. Synthesis requires coordinated intracellular processes. Lactose is synthesized in the Golgi apparatus. Lactose determines osmotic water movement into milk and largely regulates volume. Proteins are synthesized on rough endoplasmic reticulum and transported via secretory vesicles. Lipids are produced in the endoplasmic reticulum as cytoplasmic lipid droplets that are secreted by an apocrine-like mechanism, forming milk fat globules enveloped by plasma membrane. Immunologic components such as secretory IgA are produced locally by plasma cells in the mammary stroma and transported into milk. Tight junctions between alveolar epithelial cells regulate paracellular passage. After parturition, tight junctions close, directing secretion through controlled transcellular processes. Milk composition and temporal changes. Colostrum, produced from birth to approximately day 3, is low in volume but rich in protein, immunoglobulins, particularly secretory IgA, lactoferrin, and bioactive factors. Transitional milk follows for about a week, and mature milk is achieved by 2 weeks postpartum. Mature human milk is dynamic. Its composition varies across a single feed and over time. Foremilk is relatively lower in fat and higher in lactose. Hind milk, obtained after more complete breast emptying, is higher in fat and energy. Milk composition also adapts to infant age, diurnal rhythms, and maternal diet to some degree. Human milk contains immunologic cells, oligosaccharides that modulate the infant microbiome, and hormones that may influence infant physiology. Principles of maintenance, supply and demand, feedback, inhibitor of lactation, FIL, and mechanical removal. The central principle of ongoing milk production is supply and demand. 2 interdependent mechanisms govern this. 1. Systemic endocrine stimulation. Regular suckling stimulates repeated prolactin surges that prime alveolar cells to synthesize milk. 2. Local autocrine control. Milk removal itself regulates synthetic activity. When alveoli are full, the concentration of a whey protein known as the feedback inhibitor of lactation, FIL, accumulates and downregulates further synthesis. Regular emptying reduces FIL concentration and promotes continued production. Therefore, frequency of suckling or expression, completeness of breast emptying, and effective latch are the strongest determinants of sustained supply. Factors that impair or enhance lactation. Multiple factors influence lactation. Promotive factors. Early and frequent initiation of breastfeeding, skin-to-skin contact immediately after birth. Effective infant latch and suckling technique. Adequate breast emptying, either by feeding or by appropriate pumping. Maternal rest, hydration, and a supportive environment minimizing stress. Impairing factors. Insufficient glandular tissue, prior breast surgery that disrupts ducts or nerves, or congenital anomalies. Maternal medical conditions, severe untreated hypothyroidism, polycystic ovarian syndrome in some cases, uncontrolled diabetes, and certain endocrine disorders. Pharmacologic agents, dopamine agonists, e.g. bromocriptine, suppress prolactin. Combined estrogen-progestin contraceptives introduced early postpartum may reduce milk volume in some women. Conversely, dopamine antagonists, e.g. metoclopramide, domperidone, can increase prolactin but carry potential adverse effects and require specialist supervision and local guideline adherence. Infant factors. Poor latch due to anatomical issues, e.g., tongue tie, prematurity, or neuromuscular problems reducing effective suckling. Procedural or management factors, prolonged intervals between feeds, excessive supplementation with formula, and incorrect pumping technique. Breast pathology such as engorgement, plugged ducts, and mastitis can acutely reduce milk removal and will require prompt management to preserve supply. Clinical management to maintain or restore lactation. Evidence-based strategies for maintaining lactation include: initiate breastfeeding within the first hour of life when feasible, support skin-to-skin care, encourage frequent feeding, at least 8-12 times in 24 hours in early postpartum, and feeding on demand, rather than rigid schedules. Assess and support effective latch and position. Correct latch issues early to prevent nipple trauma and inadequate milk transfer. Ensure complete breast drainage at each feed. If the infant cannot effectively remove milk, for example, preterm infants or poor latch, use hand expression or an appropriate double electric breast pump. Double pumping is efficient and supports prolactin-mediated supply. Manage engorgement by warm compresses before feeding, cold compresses after feeding, gentle massage, and frequent milk removal. Treat plugged ducts and mastitis promptly, maintain milk removal, apply heat, consider analgesia, and use antibiotics when bacterial infection is likely. Consultation with lactation specialists and adherence to institutional protocols are essential. When supplementation is necessary, prioritize methods that support breastfeeding, e.g., supplemental nursing system, cup feeding, over bottle feeding, which may alter infant sucking dynamics. Gradual weaning rather than abrupt cessation preserves milk supply and reduces risk of engorgement. Allow time for alveolar involution to occur progressively. Special considerations and contraindications. Most mothers can and should breastfeed, but there are situations that require individualized decision-making. Certain maternal infections, specific medications, substance use, and rare metabolic disorders in the infant, such as classic galactosemia, may contraindicate breastfeeding. National and international guidelines differ for conditions such as maternal HIV infection. Clinical practice must follow local public health recommendations and specialist advice. When pharmacologic augmentation of lactation is considered, galactagogues, risks and benefits must be weighed carefully, and nursing students should consult current clinical protocols and liaise with lactation consultants or medical specialists.